So thank you everybody for being here, being a part of our virtual seminar series hosted by the American Journal of Surgery STARS Committee. This is our Roses and Thorns of Academic Surgery series. The second, and what will hopefully be a long list of series. Today, we are hosting Dr. Callisia Clarke, um, who is a very distinguished surgeon scientist and a leader in the field. She is at the Medical College of Wisconsin, where she serves as an associate professor of surgery and chief of the Division of Surgical Oncology. Dr. Clarke focuses her surgical expertise on upper GI tract malignancies, melanoma and sarcoma. Her research, my understanding, is focused on pancreatic neuroendocrine tumors. And beyond the clinical and research endeavors, Dr. Clarke has been a champion for promoting diversity, equity, and inclusion within the academic surgery community. Dr. Clarke is very well respected and is an inspirational figure for her colleagues and peers. Everyone speaks very highly of Dr. Clarke. And she has recently begun serving as the president of the Association for Academic Surgery. And so, with her dedication to making the surgical field more inclusive and equitable, what better a forum for her to speak about her academic journey than this series that we have, the AJS STARS, Roses and Thorns of Academic Surgery Virtual Seminar Series, where one of our goals is to really promote and just have a forum for trainees at different levels to engage with leaders in the field of academic surgery and learn from them the roses and the thorns, and learn about like the trajectory it may take, how the trajectory may change over time, and just also just a forum for people to ask questions that they might not get the chance to ask like at a given institution or a conference. We're just hopeful this is another forum for people at different institutions across the nation to be able to engage with leaders. So Dr. Clarke, thank you for being here, and you can go ahead and take it away.
So thanks so much for the invitation, first of all. And I hope this will be very informal. I'll start a little bit by just talking about my history, my background, and how I really became interested in surgical oncology and specifically in diversity, equity, inclusion work in academia. But more importantly, I really want folks to be able to ask questions, and hopefully we can have some very honest and discussions in what I think is a very safe space. I'm really excited to see some of my mentees on the call, which is really inspiring for me, and then also several colleagues on the call. So I appreciate you guys taking the time to come tonight. I think my background is I think somewhat typical. I like to say I'm Jamaican, but I was born and raised in Jamaica, and really migrated to the United States after graduating from high school in Jamaica, and really primarily because I wanted to pursue medicine as a career, and my parents rightly recognized that it would probably be an easier path for me if I did all of my advanced training in the United States. So I was 17. I graduated high school early. I was 17 when I moved to the US for college. And at that time, I was already very much decided on medicine as a career, and specifically surgery as the specialty that I wanted to practice. It was sort of an odd sing because I am not from a family of physicians or a family of really, like I'd never really interacted very much with physicians, but at age 7, so I used to, so I sang competitively, and I was sort of formally trained, classically trained singer. And I started voice lessons at age 6. And so somewhere around age 8, I think, in my classroom, they read the story of Florence Nightingale, who was a nurse, interestingly enough, and would sing to these wounded soldiers. And I thought that was the story really emphasized how soothing music was. But for me, it sort of was the first thing that helped me kind of it helped me identify kind of what I wanted to do with my life, which was I really wanted to provide comfort, and I wanted to work with sick people. And I didn't really know what the term nurse or doctor really meant in terms of what your practice is, but I knew that that's what I wanted to do. And then as I learned more about, medicine and being a physician, there's something about the field of surgery that appealed to me. And I remember going to my pediatrician when I was starting high school, or which in Jamaica starts at the 7th grade. So I was like 10 years old, and I told her I wanted to be a doctor, and I wanted to be a surgeon. And she introduced me to her husband, who was a surgeon. And in Jamaica, it wasn't unusual, obviously, to have Black physicians. So this was very much a norm for me, and something that seemed perfectly within my reach. So I graduated from high school, motivated more than ever to do medicine. And then I started my undergraduate studies at a small college in Worcester, Ohio, called the College of Worcester. And what was interesting to me, a predominantly white school, very small population of minorities. There were about 26 students of color who were interested, who were pre-med, out of about 150 during the freshman year. But by my sophomore year, I was the only student of color left in the pre-med class. And it was like noticeably obvious. And it was very uncomfortable for me. Like I was not comfortable with this fact, and I was really struggling to figure out why the students were sort of failing out of introductory biology and chemistry at the rates that they were, because they were all very bright. They were like incredibly gifted students that had been heavily recruited from schools to attend our college. So it just didn't make sense that they weren't thriving. And so I remember having a conversation with quite a few of my friends, and I realized that the college that I was at was quite competitive. What was the expected baseline knowledge for an introductory class was really more of a sophomore level. Everybody had already done AP, biochemistry, biology, chemistry. So they were starting at a very different starting point. And many of the students who were often recruited from public schools within cities around Ohio didn't even have AP classes. So they were starting at a significant disadvantage, and they were never really able to catch up because they were always behind. So my first foray into DEI work, before I even thought about it, was really that I wanted to start a program for freshman students interested in pre-med that hadn't done an AP curriculum in their high school. Most of them were URM students, but it was open to everyone. And we basically started a tutoring program. I had recruited a chemistry professor and a biochemistry professor to help me. And we started that program. The first year we had about 14 students, and all 14 of them passed through the first year and went into their sophomore year. We continued that program, until I graduated. So it only really ran for 3 years, unfortunately. But But in those 3 years, we were able to get from that original class of 14, 10 students that applied to, and then actually successfully matriculated into medical school. And it was, probably a classic pilot study, but it really shaped my purpose, I think, when I left undergrad and went to medical school, because I realized that the issues were quite often sort of the same. What was funny about this is my parents are teachers, and I was adamant that I was never going to be a teacher. And I remember having this conversation with my dad, who just thought it was hilarious. And so in some ways, I think this was in my genetic makeup, but I really, wanted to continue in this work. And so when I went to medical school, my freshman year, I was more interested in recruitment of URM minorities to medical school, but then really started working on retention. And the atmosphere at University of Cincinnati was quite inclusive. Within amongst the entire class, and especially amongst all of the minoritized groups, which was actually quite diverse. We had this like no man left behind attitude, and there was a lot of tutoring resources. And so continuing a similar initiative in medical school was quite easy and much better because it was actually funded. So I sort of went through medical school, did great, had really positive experiences, and continued to, I stayed at Cincinnati for residency, fell in love with surgical oncology there, really thrived in an environment that was tough, but I had these incredible mentors, none of whom looked like me, who really had invested in me, and I always felt like they had my back. And I feel like that's an experience that every resident deserves, but not every resident gets. And there was another woman of color in my residency, and her experience was the complete opposite. And it was very traumatic for me to be in this residency and seeing like the very polar opposite experiences that we were having. And I felt like in some ways unconsciously, I don't think people were doing this intentionally, but I do feel like people invested sometimes more in me, almost as an excuse not to invest in it's almost like pitting us against each other sort of thing. And so I really didn't like that experience, and I really started talking about it very vocally as a third-year resident, and you can imagine that did not go over well. But I felt that if you invest in most trainees, most residents, we've already been through all the tests of resiliency and being smart and being adaptable and being nimble. But if you create a safe and fertile environment, almost everybody will thrive. And so, it did actually improve, I think, the investment that my colleague felt. It was never quite the same, but I think she actually ended up finishing and succeeding. But it was sort of a very uncomfortable time for me, even though I was doing really well. And then I went to MD Anderson for surgical oncology. I'd always liked basic science and translational science research. I felt like my desire to do research really married well with surgical oncology. I liked the complexity of the cases. I liked that there were a lot of questions that needed to be answered. And MD Anderson was like the place where I figured out how that would look for me as an attending physician. So I joined the faculty at the Medical College of Wisconsin, fresh out of fellowship, and I've been there now for 8 years. And it's been incredibly rewarding. It's been a fantastic journey for me. I absolutely love the institution, and I've received, I think, similar investments, and I think that's why I've continued to thrive. And in my leadership roles now, I really try to ensure that all of my faculty, all of my fellows, and all of the residents that I work with feel the same way. that there's somebody who is 100% invested in them and their success. Even when things are uncomfortable or even when you have difficult conversations. And that, I'm hopefully a safe place that they can come to when they're having challenges. I really wish that my experience was more typical. And I think what I've tried to do in my mentoring, which, frankly, and I'll get vulnerable, I feel like I did a better job of it earlier on in my career. I feel like I'm pulled in so many directions, and it's harder and harder and harder to focus as much as I would like to on many of my mentees, but they are the best. They're actually quite graceful about it. And they're the first ones to tell me, no, we understand that you're busy. So, we'll reach out when we need you. But I think that what has become more and more clear is that just across the country, there are a lot of trainees that really don't get that experience. And I think one of the things I'm hoping that we can do through some of the national societies that are really interested in this work is to be able to provide trainees in general surgery with mentorship and investment and sponsorship if they're looking or seeking it outside of their institution. So, through the AAS, it really allowed me the platform to recruit outstanding mentors, sort of the best and brightest, I think, in general surgery, that are very motivated to work with residents and help them find their footing in academia, and then hopefully retain more women in particular, more minoritized surgeons in the field, and essentially try to improve the experience of our medical students and our residents in general surgery. So I hope that wasn't too long-winded, but I think that that maybe explains sort of how I got into this space and I think it goes very hand in hand with patient care. I mean, in the same way that we advocate for patients, our trainees are no different. And I've always been, I think, a little bit more effective. So I think the one-on-one, the individual, like mentorship relationships and interactions are really, really important. But what I learned actually early on, even back in college, was that if I didn't have buy-in from leadership, everything I tried was going to fail. So if you think back to my college experience, one of the things that I did that was probably different was getting professors involved in that mentoring program. I did the same thing in medical school, and I think I've continued to try to do the same thing, in my faculty years, whether it's working with the leadership of different societies or the leadership at my institution, also making sure that you have a voice in the space and in rooms where the decisions are being made is just as important to making things better for everybody in general. So I guess I'll stop there and see if anybody has questions.
Thank you for sharing your story. And we'll definitely take any questions. Wendy, did you have one? I feel like you're ready.
You know me, Lamario. Thank you so much for sharing that, Dr. Clarke. I particularly loved your story about, seeing your co-residence experience and how that's different. I think many of us in residency, even in med school, you see people have different experiences. And some of that is just luck.
Yep.
But definitely sometimes it feels like a kind of continuation of privilege for some instances, or sometimes, like you said, about folks being pitted against each other. And I think as trainees, like how to speak up in those instances is so hard. So I wasn't sure if you'd be willing to expand a little bit more on specifically how you went about that, what some of the language you used were, who you spoke to about it. I know it made people uncomfortable, but I'm just just curious about if you could expand on that some more.
Yeah, so it was kind of challenging, but I think the first thing that, and it wasn't just me, I think one of the reasons our voices were essentially heard were that the residents were actually unified in the idea that we needed to do better with this individual. And so that really helped, right? I think if I was the only person speaking up, I don't know that it would have been heard as well, but I would say that my co-residents were fantastic. My chief residents, or there were the rising chief residents were actually really fantastic. So I think we started talking about it as residents. There were also some individual faculty members that were key players. And what we did was we leveraged individual relationships with those faculty members and had residents who had some leverage, some connection with those faculty members, actually talked with them a little bit about what their perceptions were about how the program could do better. And I think that allowed for some of the faculty that we really needed to have strong buy-in to actually listen and receive and participate. And then once we got a little bit of cohesiveness there, then we sort of talked in a more unified voice to the program leadership. And, we actually didn't, probably one of the things that I think I would do differently, we didn't necessarily, we had these conversations without involving the resident. And I don't know if that was right or wrong. I felt that it was, I think individual conversations with the residents, there's a lack of trust that happens after you've been mistreated, right? And so at some point, these conversations aren't really being heard. And I felt like at this point, it might be best to just sort of see what we could do to change the climate. And, but fundamentally, I think I was at an institution where we really wanted everybody to finish, right? There was not this appetite to just weed people out. And so I think if that wasn't there, then we probably would have had a different outcome. But I do think that, having some strength in numbers amongst the residents is really important. Having a playbook because there's a lot that residents do, especially senior residents in your day-to-day rounding responsibilities, operating room responsibilities, that you can tailor somebody's experiences quite a bit. So I think that was really critical. I think leveraging relationships between residents and senior residents and faculty allowed for, I think, more open dialogue that was received well. And then a system in which there really was a strong commitment to all of the residents, even the ones that weren't being as invested in, really allowed for there to be change. But it's difficult. And if the culture of the residency and the program is not very trainee centric, then it's very easy for things to go off the rails, so to speak.
Just as a kind of a conclusion of that story, would you be able to expand on some of the things that you feel like they were able to do after there was consensus to help make the experience better? I feel like sometimes in programs we feel like we don't have a lot of flexibility because the services are just so tight,
right?
In terms of helping folks, if there are deficits that need filled, like to even know how to adjust things.
So I think, the first thing, honestly, that we did was we changed our language, and I had to do the same thing, right? I think we, as residents, talk a lot, and sometimes you don't even realize the power of your words. So one of the things that we had to do was make sure that we weren't a part of the labeling that was happening, and that we were going to be very thoughtful about how we communicated about either, shortfalls or deficits, and how we were going to intentionally try to address those. So I think that was probably the main thing that was different once we started talking, and that really included myself as well as others. So that's always hard when you start looking at like, well, you know, I'm sort of part of the problem, and so I need to be really cognizant about my words. The other thing was there were simple things like, you know, when looking at case assignments, for example, and thinking, okay, well, we're gonna get you some time with this attending, but they're pretty challenging in the operating room. So let's get you some FaceTime with this attending who really teaches a lot and sort of is a little bit more patient, so that you can get familiar with this procedure for the next couple of days. And then we can get you in this room. And that doesn't have to be stated. That's something that you can do on your own as a chief resident. Or think about teaching cases. So that's another thing. Like if you are a chief resident, you know, being the person to take an individual through a case or a critical case and really do some of the fundamentals of surgery coaching. I think that was one other thing. And then utilizing a rounding time as almost like mini didactic sessions, especially for evening rounds. You usually don't have the time on morning rounds, but if there are sort of gaps in disease site management or that you identify, you know, throughout the day, then you can really try to do some focused addressing of that. And it doesn't, and all of this was sort of, I think, being done, you know, without discreetly saying what we were doing. And so I don't think that individual felt targeted or remediated in any way. But I think it was actually quite effective. So those are some things that you can do even as residents. Somebody put in the chat.
Yes.
What are some telltale what are some telltale signs that you're not being invested in? Well, I think we've gotten a lot of data from other people about this, and I think is one of the common themes that we get is, you know, seeing that opportunities are being offered to others and you're not necessarily getting the same opportunities. Mentorship is a big part of being invested in. But I think ultimately people really know, and it's a gut feeling. You kind of understand, and sometimes there's an acute event that changes it. Sometimes it's sort of always been there. I usually ascribe to the fly under the radar sort of personality, so I didn't necessarily want or seek out a ton of mentorship. I felt like if I wasn't getting in trouble, then I was doing okay. That's really not the best approach, and you really want to try to find at least one person at your residency that you can, one faculty member at your residency that you can connect with, that you can have conversations with in a safe space. But it requires a lot of times intentionality in seeking that person out, and that's where I think we can do better as individuals. It sometimes is difficult to go outside of your comfort zone and ask for direct mentorship, but I do think it's perfectly reasonable to say, you know, hey, Dr. So-and-so, I appreciated how your patients in this case with me the other day, or the time that we spent together in clinic, you know, I don't have an active mentor in residency right now, and I was hoping that you'd be willing to just be a sounding board for me if I have any challenges or if I have any questions. I think it's perfectly acceptable, and I think I would strongly encourage people to do that, because you won't always have somebody who's like, hey, I'm here, I want to be your mentor. And so asking is really beneficial. So my research, yeah, I saw that. So another research in surgical oncology. Oh yeah, so I have two particular interests in on the translational side for my cancer research. So one is just epigenetic regulation in particular for neuroendocrine tumors. So these neuroendocrine tumors are relatively rare cancers. They're genetically quiescent, so there are not a lot of mutations that are driving these tumors. And so really what we think is the major driver is the epigenetic regulation. So the regulation of the genome that happens separate from the genetic makeup. The hint that this was the case was that most of the genomic alterations that we do see, even though they're few, have to do with epigenetic modification, either through like telomere like folding or DNA methylation. And so that was sort of like a clue that that's where we were having some challenges. So I started looking at epigenetic modifications of neuroendocrine tumors that drive prognosis and tumor grade. And then quickly realized that, you know, if we're looking at epigenetic regulation, then some of this is genetic, but also how much of this could be just the social factors and genetic factors and hereditary factors that we have that may contribute to how tumors are modulated, and does that impact tumor biology and outcomes. So I have an interest in ancestry and the impact of ancestry on the epigenetic regulation of tumors within similar stage. And also on other socioeconomic factors like obesity and some other confounding comorbidities that may regulate the genome of these pancreatic neuroendocrine tumors. And then my other interest is actually in pharmacogenetics, why some people respond differently to different medications, and specifically there are some disparities by race and ethnicity in terms of response to treatments that I'm trying to understand a little bit better. So those are the two areas that I am interested in. It really marries well to being a surgeon because, you know, I have access to the tissues that I need to look at. So I was able to build up a pretty robust tissue bank through an existing surgical oncology tissue bank infrastructure, but I enrolled a lot of patients in that protocol that I'd operated on. So now really we have a ton of bank tissue that we're investigating, and I'm working with a PhD collaborator on that. So I really like that work, and it allows me to, you know, it allows me to ask questions and generate hypotheses and figure out how to test those hypotheses. It's a really important part of why I wanted to do academics in particular. I think that and working with residents and medical students were my two big reasons for academia. It is exciting. And I think, you know, research isn't easy, especially when you're clinically busy. And I think the nice thing is that I'm almost as excited when I'm in the lab space as I am when I'm in the operating room. So that's when you know that you're doing the right thing.
Any other questions? Jane has one in the chat.
Yeah. So, gosh, my mentors. You know, my first mentor in surgery is really why I'm a surgical oncologist, and is Andy Lowy. He's a surgical oncologist. He's now the division chief of surgical oncology at UC SD in San Diego, but he was at University of Cincinnati. He was a surgical oncologist there, and he was the division chief when I was a medical student. Easily one of the most brilliant people I've ever met, incredibly talented, a true triple threat, in that he's basically an incredible surgeon, very technically gifted. He has been NIH funded for like his entire career, which is 20 plus years. He's clinically busy. So he's not the surgeon scientist that doesn't operate and mostly is in the OR. He's like really busy. And for me, he was a master educator because he, as a medical student, I really messed up on a case with him. Like, he asked me a simple question, I didn't know it. And I was like, oh my God, he hates me and he's never going to talk to me again. And he didn't talk to me for a couple of days. He'll deny that part of the story. But eventually he asked me another question and I sort of nailed it. And I remember he chuckled and he was like, so you know all that, but you don't know whatever the question was that I missed, you know? And it sort of started this relationship where he would really challenge me to he would ask me really tough questions and he would really challenge me to learn more about the disease. But more importantly, I think, you know, I never quite knew, I felt like I was doing a great job with him. A good job with him, I mean, not great job, but I didn't think I was doing a great job. I knew I was doing a good job, but not a great job on the service. But at the end of the rotation, he says to me, when's your last day on the service? And I told him, he's like, you should come to my office and meet with me. And I'm like, oh God, what did I do now? And he basically had a conversation with me about, I think that you would make an outstanding surgeon and I would love to write a letter of recommendation on your behalf. Like, I mean, that was just, I mean, I'd never experienced any sort of investment like that before. And it seemingly completely out of the blue. And from somebody who was so respected in the field, it really made me feel like I belonged. And I felt like if Andy Lowy thought I was worth it, then I was actually worth it. And this is a time when, you know, I started residency in 2006. So this is in 2004. There were not a lot of women in surgery. It was still very taboo. And nobody said, no one was coming up to women and saying, you should be a surgeon. So it was a really striking experience for me. And it was really, I think, ground setting for me, and just really, I think it set the tone for the rest of my career for whatever reason. The other person who invested in me was actually my chair at the time, was Jeff Matthews, who is now the chair at University of Chicago. He actually said the same thing. And he said to me, which was, I thought, very crazy as a fourth-year medical student, he says, you know, Callisia, I think you have what it takes to be a chair of surgery one day. And you're just like, where does this even come from? Like, I even know what I wanted to do. And I think if anybody knows Jeff Matthews, he's like the nicest person ever. And I'm convinced he says this to every medical student. But for whatever reason, I believed it. I believed that there was something that I had that was special. But I applaud these men because I was nothing like the people that they had mentored before. And while they weren't perfect mentors, I think those words meant so much to me. And so I really do try to give everybody a little bit of encouragement, you know, just a little bit goes such a long way. And what's interesting is, you know, they barely remember it, which is so funny. So it was a profound impact on me. And they're like, oh yeah, of course you were great. I'm like, yeah, exactly. Right. You don't remember it, but it meant a lot to me. And I think for many of us, we have never heard those words. And so I was really fortunate to hear them early. And then throughout my career, so those were really fundamental ones for me during medical school and then residency. At MD Anderson, my research mentor, Scott Kopetz, was actually a medical oncologist, but he really helped me envision what my research was going to look like as a surgeon scientist. And specifically, he, you know, a lot of people poo-poo surgeons as researchers, and he loved my skill set. And he loved that, you know, I was there earlier than everybody and left later. And he basically, you know, told me to be confident in the research space. And he knew that there were going to be naysayers, but that I had everything that it took to be successful. So I think he was incredibly inspirational. And then, you know, I would say that in my professional career, I've had some incredible sponsors. Like, you know, I won't mention all of them. I'll try to mention just a couple. You know, Sandra Wong, who is just an incredible mentor and sponsor. again, similarly invested in me out of nowhere after I met her randomly. And I'm eternally grateful for her and her example. There's still not a lot of women leaders in academic surgery, and she has done just such an impressive job. Kelly Hunt, who I met at MD Anderson, is another one that's been very, very impactful to my career and has mentored and sponsored me. And much later on, actually, in my faculty, I met Andrea Hayes Jordan, who was the first mentor that looked like me in any way, right? So I say that to say that a lot of times your mentors and sponsors may not walk the same walk that you have, but they can be incredibly impactful. So how do we encourage faculty? So I'll have to tell you that most of that work that I'm doing is through the AAS and through the second trial, the partnership that we have with the mentor match program through the second trial. In some ways, it's easier to not clean your own home. Does that make sense? I think that there are a lot, what I found in the AAS, me included, that there were a lot of people that were disillusioned sometimes with the cultures at their home institutions, and they really wanted to make a difference, but they weren't sure if they could, or if they, if it was enough. And they were struggling to change the culture from within. And I think the mentor match program really allows for you to make an impact on another resident at another program with almost like a fresh start. And it also it's a little bit easier to help somebody navigate the challenges in an environment where you don't feel like you might even be contributing to the problem. And that's certainly been, my experience too. I really felt like I could make a bigger impact outside of my residency program. And so that's where I started. I then came back to my residency program and I was starting to do a lot of work there. But, when you're a brand new faculty member, like nobody really cares what you think. And, you're struggling to set up your practice, which is complex, and you doubt, am I the most patient teacher in the operating room? No, like I can comfortably say that no right now. But when you're new and that that's not the case, you sort of come from a place of insecurity and you're like, well, I don't know if I should be focusing on resident education here because I'm not the best educator, right? And so it was actually much easier for me to do this work outside of my residency program. And I was always like the place where all the residents could come and chat and tell me if they had issues. But in terms of truly trying to push the culture change from within the system, I didn't really feel like I had a lot of leg to stand on. So I think a lot of the work that we're doing through the mentor match program really allows for these connections outside. And for residents that are struggling at home, they are less likely to seek input from their home faculty members because that trust is broken and the communication lines are flawed. And so almost every resident that I work with that is having trouble in their home programs, I haven't really worked, well, thankfully we really haven't, that's not true. We haven't had, since I've been there, I've been sort of very active on the one committee is the CCC committee that I was very active on. So I think, we squashed the major issues of people being dismissed and all those things through that system. But when I talk to residents from other programs, the cycle is almost always the same. Things were going really well. Then I was labeled as unprofessional, not smart, whatever. Typically by the residents first, then the faculty, then that individual pulls away. And by the time there have been, remediated or put on promotion, the lines of communication are so broken that it's almost like, how can we fix this? And so I think that taking those individuals out of their programs a little bit to a place that's safe allows them to really have communication that's a little bit more impactful. What we would love to do is see if we can operationalize this even more and have this as almost like a third-party service to residents and the ACGME. Because what I've realized is if you can get that individual either into a new environment or a different environment or under a new leader or program director, with a little bit of investment, things can actually turn around quite quickly. The problem is we do it too late. And so I do wonder if we can intervene earlier, could we? So that was a long-winded way of saying. The way I encourage residents, faculty to invest in trainees is I do reach out to faculty members that are interested in mentoring and investing in trainees that are outside of their specialty, and usually not outside of their specialty, outside of their institutions, and in many ways that they connect with their mentors on one particular challenge that they're going through. So with the mentor match, you could tell us everything that you want in your mentor. And so, you know, if you were having children during residency and you want to talk to somebody who made the same decision and had some challenges, you know, re-entering, those mentors connect very well with residents that want to talk about those topics. If you went through a divorce in your residency and you want to talk through that with somebody, if you're a religious minority and you're feeling some discrimination because of what you wear to work and you want to talk through somebody about that, then so we try to connect the mentors and the mentees that have based on some commonality that allows for a little bit more of a safe space to discuss this. And I think people invest in people that they see themselves in. And that's fundamentally the problem, I think, with residency, and why we see so much disparate experiences for trainees. And so I think by trying to make some connections that are a little bit more organic, where people feel seen and feel that they have a commonality, I think those mentorship relationships are often more successful. Not always, but often. So yes, the mentor match is still ongoing, and I can send out the intake form for that, and then maybe somebody can distribute it to the group. We're expanding it actually, so, and we need more faculty mentors too. So I think I just saw Jennifer join. I think Jennifer, I think you're one of the mentors for the mentor match, but if not, we'll recruit you.
I'm not, but I was actually just thinking I would love to be a part of it.
That'd be great. Yeah, it's a really fun group.
I do the second mentor where it's just like you just mentor somebody else, but not necessarily people who have a specific issue that they're trying to work through.
Yeah, some of them do, some of them don't. So
okay.
Everybody,
well, in that case, I do participate in the second trial, like that.
Right. Then yeah. you're one of our mentors. I knew you were.
Okay, good. Yeah.
But
sorry for joining late.
No, that's perfect. But sometimes we'll have somebody that reaches out and they specifically want to talk about something, and then we go through all of our mentors and we basically do a call and be like, hey, I have a resident who's interested in talking about this. You know, does anybody want to tackle that? And then we can pair them that way.
I know you mentioned, you know, a lot of your focus is on the faculty side, but you kind of acknowledge that kind of some of these issues start with residents and kind of their labeling and almost like isolating a resident. From your experience talking to other, you know, residents who've been going through challenges, and I know you do some work with like attrition, you know, have you heard any stories of things that people's co-residents have done that have been helpful to help like minimize those experiences? Like, what are things like residents can do besides personally not using language to help, be an ally and an advocate, when they see that happening to someone?
I mean, I think that that's actually the best thing that and most effective thing to do is really try to advocate as much as possible. I mean, peer groups are always really important. And so one of the nice things about residencies, you sort of have an automatic peer group, in your co-interns, and really trying to establish a culture within the residency where that team is a solid team and no one person is outside of that team. I think that's really important. So trying everything you can to create and then maintain that culture is really important. Reaching out to students when they withdraw is probably the hardest thing to do, right? And it's not a one-off. It often requires persistence, right? But the self and social isolation is the beginning of the end for any resident that's struggling in residency. It's really hard to communicate that. But once you are a man on an island or a person on an island, you have started to fail. And so I think where residents can be impactful is trying to prevent that particular problem. Always try to make sure that we're bringing people into the fold as much as possible. The rest of it is difficult. It's not up to residents to serve as mediators, right, between program directors and associate program directors. I see that a lot. I feel so bad for the residents that are having to do that. It is distracting to their own education. And sometimes they get retaliated against or penalized for it. And so one of the reasons that I don't focus on, well, what are residents doing? Well, because one, this is a learned behavior. It's usually not repeated if the culture is one that's inclusive and safe. So that's why I focus on faculty. And two, almost all residents, they don't want to see their co-residents fail. And they are not the ones that ultimately can or are responsible for changing the experience of any one residency. But I think for those who want to help and feel a duty to support their individuals, those are some of the main things that you can do. And then anything else from, simple things from like, study groups and, reading time together and sharing the tips and tricks, the hidden curriculum of what to do and not to do on a rotation and what to do and what not to do with a particular attending, sharing all of that as equitably as possible so that everybody has the same, leg up when they're starting those rotations. Those are some of the actionable things that we can do. But I'll tell you that the vast majority of residents are doing it.
Hi, Dr. Clarke.
Go ahead.
Can I ask a question?
Yeah.
Hi, Dr.
Yes.
Clarke. Apologies for my tardiness, fresh from the OR. Thank you so much for joining us tonight. Regarding faculty and faculty development, I try to come to my program with alternatives or solutions when it comes to just improving the learner environment and experience. Would you say that, have you come across like really robust programming for faculty development or an incentive type system or, okay.
No. So academic surgery is so flawed, right? Because this is the only specialty or only field in which you're responsible for somebody's education with no formal training about how to do it, right? So that's number one. Number two, the pressures from hospital systems, patients, family members, colleagues for perfection and the intolerance of complications has really created, I think, a huge shift in the educational experience for trainees. And I don't think it's wrong, but I definitely know that, the amount of rope that I was given as a resident is not the amount of rope that I give a resident anymore. And so we're all trying to learn without any, one, actual time to learn, and two, incentive to learn how to be better educators in the current healthcare system. So the one formal program that I'm aware of is one that Caprice Greenberg does, and it's basically it's a intraoperative coaching program where she's focused on teaching faculty how to be better coaches or teachers in intraoperatively. And it's really about, being self-aware about your hang-ups, and then being able to sort of create a culture of safety by more eloquently using your words, and how to show, how to take residents through sort of challenging situations. But that's the only formal program that I'm aware of. The rest of it, we sort of do as you go. And a lot of it, now in my leadership role, I realize a lot of the formal how to be an educator stuff is actually done to remediate faculty that have been identified as poor performers or major outliers. So I think in general, we need to do a better job of doing some formal educational curriculum for faculty members. This sort of see one, do one, teach one mentality is really suboptimal, but it's really how this system was built. And no one has ever been a formal educator, and all they've done is be a resident. And that's the only qualification for being a faculty. So I think the system is flawed. We are trying to do a series of lectures. This is new, and this is the program director, the new program director at MCW is instituting this. And we haven't had the first one yet. I think they're just 4 sessions that is going to be talking about surgeons as educators and how we can be better at it. But that, I don't know of a lot of formal. And faculty don't want to hear that they're not being good teachers. So they're not really receptive. And I include myself in this, you're not as receptive as you think, Sharna, to your very kind words and profound suggestions. They often fall on deaf ears because everybody else just feels like they're being pulled in so many directions, right? So unless you force people to slow down and listen, and that has to come from the leadership, I don't know that you can make as much impact as you think.
I wonder if that would make a good pre-meeting course for the ASC, right? We have the ones that are for research. Maybe there should be one for educators. I mean, I think that sounds like a brilliant idea.
That's actually, and we can talk about that offline. I mean, I think that's actually a really good point. Yeah, let's talk about this offline.
Yeah, I think you have the content. I mean, I just think timing wise, maybe that would make sense. So just, building on what you're already doing. I mean, the timing seems like it could be great for those that are more interested on the teaching than the research, but would get more people there. I don't know. Anyways, yeah, I'd love to talk about it.
Yeah, I kind of love that. That's great. See, Sharna, you solved the world's problems right there.
I'm just trying to be like you when I grow up. Thank you.
I want to be like her too. Me too. Me too.
Me too. I know we're at time, but just to kind of back up what you were saying, I know there's been a lot of discussion of EPAs, and it feels like an attempt at kind of institutionalizing or, creating a process for focusing on resident development. And I'm not sure if Wisconsin is one of the institutions that's trialing them now.
Yeah.
But I'm just curious of your thoughts about how that will it actually help invest in residents, or will make it easier to fire residents? I'm curious of your thoughts of which way it's going to go.
I mean, well, here's the thing. If you're at a program where you have to ask that question, that's really disturbing. And I really hope that nobody feels this goes back to where, when I say we're like, gosh, I mean, the culture needs to be that, everybody's going to finish for them. You have to be able to recruit enough And you know that's not always going to happen, right? But that should be the goal. So I really hope that nobody ever looks at this that way. As a person who has been the most delinquent in terms of filling out monthly evaluations, I have really embraced EPAs because to me, when I was a resident, that is what I wanted. I wanted feedback that was associated with a defined experience, operating room in a relatively short term turnaround so that I could remember what happened. And I could then connect the feedback to a case, an interaction, a patient, and then actually make it impactful. Like, so the feedback needed to be something that I hated the fact that I was seeing my evaluations 6 months at a time, and who knows what they were talking about. And I didn't find it helpful. So even as a faculty member, I hated doing these evaluations. I felt like I would just check a number and move on because I couldn't even remember, like, all you remember are the outliers, like the major great saves. Oh my God, this resident saved a patient that was actively coding. Or like, I had the worst experience in the operating room, but everything else in between is all gray. But the only things that show up are the negative things because that's what you remember. And so I really didn't like monthly evaluations, and I was like the most delinquent person on doing that. So EPAs actually, when we started trialing them, I immediately embraced it. It was easy for me to do. It was tied to a particular incident, and I could do it on my phone, which was easy. And I quickly became I put in the most EPAs. So I've gone from the worst to close to the top. And in fact, MCW is like in the top 10 users for EPAs. I think we've done like 800 or something in a really short time. So I think in general, the faculty, I think, like it. And I like it, I think, because of all the reasons that I hope. So I hope that residents will like it for that reason. It allows you to actually also measure, how did I think that case went? And does it actually match up with how my faculty thinks the case went? And I think we get rid of that recall bias that can be very damaging to residents that are struggling, where for the whole month, you know, most everything was fine, but you have one interaction that was terrible. And that's what shows up on your evaluation. And then that basically stays with you the whole time. So in my opinion, I think it's better. The more points of evaluation that you have, the more equitable it's going to be, without a doubt. And then also what I would recommend is for residents, when you give out an EPA when you assign an EPA and you get one, read it immediately. Make sure it matches up with your experience. And if it doesn't, then you have an opportunity to go back to that faculty member and say, hey, thanks so much for filling out that EPA. Boy, I thought the case went better than you thought it did. Can you walk me through which parts of the case you would want me to focus on and why? And I think that if those conversations happen even once in a year, it's probably once more than it would have normally happened. I think without the EPA. So I think if they're used well, they could be very, very helpful.
Dr. Clarke, would you mind if I ask one more question?
Oh yeah, I'm here for you guys.
So talking about the mentoring, it seems like you've found that it really helps, and it really helps to just talk through things with mentors. But I'm wondering how this compares with talking through things with like a therapist potentially. And do you think there's potentially like barriers to surgeons with therapists due to surgeons perhaps being like very high functioning or having like insight that limits their ability to respond well to suggestions from therapists? And so does this mean there should be more urgency for expanding like a mentoring network where like residents can feel more comfortable talking about their difficulties with other surgeons and staff therapists.
So 100%. And when I'm working with a resident, especially a resident that is being remediated on probation or has been dismissed, it is essentially a mandate from my part that they actually seek out a therapist, because almost universally, the amount of anxiety and angst that comes with being put in that situation, I don't think there's any one of us that could actually tolerate that without significant self injury. So it actually goes hand in hand. And if they don't address the mental health part, then we can't even get to the, let's get around to, figuring out how we can, change the educational experience. So they go very hand in hand. One of the things that I need to emphasize is, as residents, believe it or not, this is the most access you'll ever have to mental health care, because it is obligated that it be provided to trainees. I will tell you that as faculty, it's not. And depending on how your employer is structured, if the mental health services are offered through an employee program, those records are essentially the employers. And so you can see that if somebody's having an issue that's work-related, using the employer offered services can sometimes expose that individual to their employer. And so many people feel that it's not safe. That is not the case for residents. And so with trainees and medical students, I encourage them as much as possible to utilize these services, because they're as accessible and for the most part, I'm pretty sure they're free for everybody. So so you need to utilize them now as much as you can in training. It's probably the only time that you'll get that opportunity. I think in surgery, it is very, very challenging as a faculty to really address mental health issues. And I think many of you guys listened to Carrie Cunningham's talk now 2 years ago, where she talked about her personal journey. But I now sit on the Wisconsin State Medical Board, and it is really difficult to watch how it affects surgeons even more disproportionately than other physicians in the field that need to take time off to handle their mental health issues. And we are disincentivized from seeking out care and actually getting them in a lot of ways. So I completely agree with you that we do need rapid expansion for these services. And I think targeting surgeons is especially important. We know physician suicidality is higher than the general population, but within surgery, it's higher than many of the other subspecialties. And so we're at highest risk for this. And, I think what Carrie did with her talk is probably more impactful than anyone else could have done for academic surgery. And it really humanized a problem that everybody has been very reticent to talk about. So if you haven't seen it, you should Google it. It's on our YouTube channel through the AAS. It's called Removing the Mask, I think. And it was a presidential address. It's the last one up, actually, because Fabian's hasn't gone up yet. So if you go to our website, it's there and you can watch it. It is a must see and must listen. But the ripple effect of that has been that she has been working with state medical boards to make it easier for physicians to enter, either self-monitoring or rehabilitation programs for any sort of mental health issues, many of which are not addiction or alcohol or substance related. A lot of it is anxiety, depression, significant depression, but it allows people to enter into programs for physicians, but have that be protected and not reportable to your employer or to the licensing. As long as you self-refer, then there are no consequences to the physician. So that's really the the impact of that is sort of working at the state level to try to make this easier for physicians to seek help.
Well, I really want to thank you for your time and appreciate you being so open with us and answering our questions. I've learned so much in this short amount of time, so definitely really appreciate you. Want to try to be respectful of everyone's time. So we'll go ahead and conclude. But Dr. Clarke, again, thank you so much for lending your time, your expertise, your wisdom, your vulnerability. Thank you for being here and talking with us.
No, thanks for having me. And I have to, shout out a couple of my mentees on the call, Sharna, Shamia, Tamara. I'm so excited to see you guys. You are the blessing, not me. I'm really proud of the work that all of you guys are doing. And I think we're all somewhat due. Tamara, I just talked to you. Shamia, we need to chat. Sharna, we need to chat. Anybody else that wants to talk, we should talk anytime.
Thank you so much. Good night, everyone.
Thank you, Dr. Clarke.
Thank you so much, Dr. Clarke.
You're welcome. Thanks for having
Have a great
me.
week.
You too. Bye, guys.